Give us a little signal when you want us to laugh.
Yeah,
So.
still.
Let's decide what that's going to be. Okay.
Okay, how's everybody doing? Good, good. So yeah, we are winding down, right? This is our last lecture together. Then you have one more with Miss Klepper.
No.
Right? No? You already did both of yours with her?
We have Sim and ATI.
Sim, that's what it is, right? Sim, ATI, and then final exam, right? It goes by quick, right? So, let's get started with cardiac. What's up?
Sign up, or is it just?
There's Sim sign up? No, I'm just going to have half of you do Sim first, half of you do ATI first. Yeah, pretty quick. Okay, so we're doing cardiac. Who here enjoys cardiac? Right? Who is intimidated by cardiac? Okay. A little bit. Well, what is the heart? Just a muscle. It's just a muscle. It goes kaboom, kaboom. And that's about it, right? It's not actually as magical as people think it is. It's a muscle. It's a pump. So don't be intimidated by it. But what I will say is that one of the things that you really need to be familiar with is the normal anatomy of the heart and also the normal flow of blood throughout the heart, right? So I'm not going to have you do this on your phones, but we'll do it together. Let us trace blood flow through the heart, okay? Start there. So coming back from the body, where do we start? Okay, so the vena cava. And we have, superior and inferior, right? Cool. Then where do we go?
Right atrium.
Everybody feel good about that? Right atrium? Okay. Right atrium. Then we pass through
Tricuspid.
tricuspid. Okay, tricuspid. USD, tricuspid. Then right ventricle. Okay, and then we have a big swoop, and we go through
Pulmonary
artery. No,
vein.
artery.
before that even.
Oh, the pulmonic.
The valve, right?
Yeah.
Pulmonary valve, yep.
Yeah.
Pulm valve. And then to the okay, pulmonary artery. And what makes this artery special?
It's the only one that has deoxygenated blood.
It has deoxygenated blood, right? So it's the blue blood. Why is it an artery then? We're going away from the heart. That's right. Okay, and then from the pulmonary artery, we're going to go to our lungs. Okay, so that's what these are. Look, here's the little stem. Oh, respiratory therapy was so proud of me. Okay, now lungs, we come back to pulmonary vein. And what's unique about this?
It carries oxygenated blood.
It's a vein with oxygenated blood? What? What? All right, so now we're
Left atrium.
left atrium. Everybody feel good about that?
Yeah.
Okay. Left atrium. Boom. We go through the.
Mitral valve. AKA mitral valve.
Yeah, bicuspid or mitral. I like mitral. I think it's cool. Mitral. All right, and then to
Left ventricle.
left ventricle. Boom. Where are we going to go?
Aortic valve.
Aortic valve. And then aorta. And to our body. And that's a smiley face, because we are perfusing nicely, right? All right. So everybody feel kind of okay with basic anatomy? Yeah? So if you're familiar with the basic anatomy, it's easy to see how the different exemplars, or how changes in the anatomy can really affect perfusion, and how our different exemplars fit into all this, okay? Here's a good question. Where is the area of highest pressure in the heart of a normal child? We have one vote for left ventricle. Anybody else think something different? It's definitely the left ventricle, and that's really important. Okay? In a normal child, the left ventricle has the highest levels of pressure. Okay? And it's important to know about pressures because that's what's going to cause shunting, that's what's going to cause blood to flow in weird ways with some of these abnormalities. So it's important to know where pressure is normal. Okay. All right, so here's what we traced, right? Pretty standard. That's our regular heart. You're going to see this pop up in our lecture over and over again. Normal heart. We traced everything. We know where the oxygen-poor blood is going, where the oxygen-rich blood is going. We are good. Right? Awesome. So let's talk fetal heart versus newborn heart. You all have had maternal newborn. Okay, so what are some of the differences between the fetal heart and the newborn heart?
Foramen ovale until a certain point.
Right. So
It's big.
yeah. So the foramen ovale. Oh, no, it's the second one that gets circled down here. Right. You can see that's circled in blue. Foramen ovale closes after birth. Right. And what else closes up? Right. So the patent ductus arteriosus becomes the ligamentum arteriosus. Right. Now, the closure is triggered by different things. So each of these things happens for different reasons. Let's talk about the patent ductus arteriosus. So first off, what does it do? What does it allow?
Shuts the blood from coming to flow into the lungs, back into circulation.
Right, so it shunts blood that was going to be going this way back into circulation, right? So it connects the aorta and the pulmonary arteries. Okay? So it connects those two. Now, upon birth, there's a few things that trigger the closure of the PDA. One is going to be the absence or declining levels of prostaglandins. Okay? What do you know about prostaglandins? Where do those come from? So if right after birth the levels start going down, where do you think they come from? Mom, they come from placenta. That's right. And they don't go away right away. It takes a while for them to decline. Okay? But declining levels of prostaglandins gives the PDA a hint. It says, oh, you might want to start thinking about closing, because I think we have a different task. Okay? The second thing is increased O2 levels. So oxygen levels go up, and the PDA says, oh, I don't think I need it anymore. Let me double check with the prostaglandins. Yep, those are going down. I'm going to close up shop. Okay. So PDA is closed by two things. One is declining prostaglandins and rising oxygen levels. Both of those things must be met in order for the PDA to close. So what are the two ways to keep a PDA open? Give prostaglandins. Yep, we can give those artificially. Or lower O2 or don't allow a child to fully saturate, right? Remember, I think during one of our lectures together, I talked about how certain kids might have goal sats of between, let's say, 75 to 85. Why do you think that is? We don't want their PDA to close. So we actually don't want them oversaturated. We don't want them any higher than, let's say, maybe 90. So their goal is going to be much lower than that of a child with a normal anatomy, and that's because we're trying to keep that PDA open. Okay? Questions there? No? Okay. PDA will close about 10 to 15 hours after birth. 10 to 15. So fairly quickly, right? Yeah.
I was just gonna ask, do they try to prevent that to decrease the heart's work after birth?
Prevent the closure?
Yeah.
No, not exactly. We'll talk about, once we get to some of the exemplars, it'll kind of click as to like, oh, that's why we might want to keep that open. Okay? So great question, and that will be covered. Now, foramen ovale closes really quickly. It closes right after birth. And actually the closure is triggered by a shift in pressure, right? So in a fetal heart, area of highest pressure is actually the right ventricle. And where's the area of highest pressure in a newborn's heart? Left ventricle. Once that shift in pressure takes place, it triggers the closure of the foramen ovale. and it should close up the hole between the two atrium.
You said the right ventricle is highest in the newborn?
In the fetal
Yeah,
part.
fetal, sorry,
Yep.
yeah.
So if for some reason that pressure shift doesn't happen, if pressure stays higher in the right side of the heart, this isn't going to close. Yep. So that only has one condition to close. Make sense? Cool. Okay, so we're going to talk a lot about congenital heart disease. It's the most common group of birth defects, 8 to 12 occurrences per 1,000 live births, so super common, right? Evidence of disease may or may not be apparent at birth. During our lab day, we talked about an innocent murmur, right? Do you think an innocent murmur is always caught at birth? No, it's not always caught, right? So that's an example of the evidence of disease and being able to actually assess for it at birth. 25% of all infant deaths. That's pretty substantial. We are, for the sake of this lecture, going to break our congenital heart disease groups into 3 different groups here. Those that result in increased pulmonary blood flow, those that result in decreased pulmonary blood flow, and those that result in an obstruction to systemic blood flow. I'll say that in reality, it is much more complicated than that, but the nice thing is that by learning these 3 groups, you can really apply this to all of the other smaller groups that there are. So these 3 groups are really beneficial to learn. So what are our risk factors? Prematurity, always a risk factor, right? Fetal exposure to drugs or alcohol, genetics, chromosomal abnormalities. Some of the abnormalities include Turner, DeGeorge, Marfan, trisomy 21, etc. Our friend on top here, anybody know what he has? Marfan's. How can you tell it's Marfan's? He's got the Michael Phelps arms, right? Really long, gangly arms. Super long. What is Marfan's? It's actually a connective tissue disorder. It's a ligament disorder, but it can have cardiac abnormalities associated with it. What about this handsome little man? So cute. Trisomy 21. Yeah. Down syndrome. Yeah. A lot of cardiac abnormalities with our trisomy 21 babies. They are also like very mischievous. So if you ever have a trisomy 21 patient, just watch them. They will figure out ways to take out their little lines. Like you can put their little arms in a restraint and their little feet will come up and take it out. Like they are so mischievous and so, but you can't be mad because they are so cute. Such cute little ones. So, but watch them. Very sneaky. Maternal viral infections, maternal metabolic conditions, diabetes mellitus, hypercalcemia, phenylketonuria. Not all that common, but noteworthy. Okay, so our general assessment, maternal health and pregnancy history. What would you like to know there? Okay, yeah, pregnancy history. What sort of prenatal care did you get? Did you get any prenatal care? Right? Is prenatal care readily available here? It is, yeah, but does everybody know that? No, unfortunately. So a lot of people go without getting prenatal care, which is really sad. What else? What else do you want to know about maternal health and pregnancy history? Substance abuse, certainly. Yep, I want to know if mom has done any drugs. When you ask a mom if she has, what do you think her general answer is? So surprisingly enough, she's generally going to be honest. She will be honest. If you ask in a non-judgmental way, and why is she so honest? Because she cares about that baby. She cares about that baby. And so if you approach her in a non-judgmental way, you're going to get a better answer. And she's much more likely to say, like, okay, they're not here to judge me, they just want to help my baby. So a lot of moms will actually tell you if they suffer from substance abuse issues. Just approach it respectfully. Anything else you want to know?
Maybe the amount of weight she gained while she was pregnant.
Weight gain, sure. Was this a healthy pregnancy? That's a good indicator. I also want to know how old mom is. Right? What's advanced maternal age these days?
35.
It's like 35. That's so sad. I love advanced maternal age. Yeah, so, but it makes a difference, right? It makes a difference in how we're going to assess this patient. We want to know about the birth history. Think back to maternal newborn. What do you want to know about birth history?
Were they breached?
Were they breached? Yeah. Were they born in an appropriate position? What else?
Term, like how far to term they came.
Vaginal versus C-section. What was that?
How far to term, like were they?
Right. Were they term? Mm-hmm. Yep. Is there a special thing we use at birth? APGAR. Yeah, we want to know their APGAR score. All right. Family history. Of course, we want to know if other kids in the family have had congenital heart defects. If there are other family members with CHDs, then the risk for this child goes up. General appearance, level of consciousness, color, everything that we talked about regarding general appearance for perfusion, right, would apply here. Vital signs, tachypnea, tachycardia can be signs of cardiac issues, oxygenation status, of course. Heart and lung sounds, what are we listening for? Murmur, adventitious lung sounds, perfect. Pulses and perfusion, comorbidities, and nutritional status. So what about our labs and diagnostics? So ECG, what is that? Electrocardiography, electrocardiogram. Yeah, it's the little stickers, right? Little stickers. What is that actually measuring? Electrical conduction. Right. So is there any time where your ECG can be normal, but you are not? If you have sinus rhythm on the EKG, are you always perfusing well? No. No, because what can happen? Precisely, yeah. So there's something called PEA, right, which is pulseless electrical activity. And that is where your heart on the ECG will be completely normal, sinus rhythm, beautiful. That patient's dead. They have no pulse. They have nothing. So it's sending out the signals, your body is sending out the electrical signals, but for whatever reason, the heart can't read those signals. It can't contract. So it could be an electrolyte problem. It could be a lot of things. However, this is just to say a lot of nurses think that if they have a normal rhythm on their ECG, they're safe, and that's not the case. This is why we always assess our patient and not the monitor, right? Always assess your patient and not the monitor. Because your monitors lie. They lie to you. Chest X-ray. What's that going to show us? So it'll show the actual structure of the heart, physical structure, maybe it's enlarged, all that good stuff. Electrocardiography, an echo. What about that? What is that going to show us? It can show us anything, right? Well, not anything, but it's really cool. It'll show you the structure of the heart, the size. It'll also show you the flow of the blood. It will show you the oxygenation status of said blood. Really, really cool. Of course, it's also used in pregnancy to monitor the fetus, right? So echoes are really, really, really handy for all these different things. Cardiorespiratory monitoring, pulse ox, cardiac cath we're going to spend some time on. Very cool process. ABGs and hemoglobin hematocrit. Right? We're probably looking for anemia, things like that. Questions there? All right. So here's our nursing diagnoses, right? We're looking at decreased cardiac output, ineffective peripheral tissue perfusion, impaired gas exchange, nutrition imbalance, activity intolerance, and fatigue. There's a lot going on with these kiddos. A lot going on. So our planning as nurses, we're going to try to detect problems early and implement timely interventions. Our interventions are going to vary greatly depending on what we're doing. Reduce the work of the heart. Improve breathing. Maintain proper nutrition. Prevent infection. Normal growth and development is really big in this population. Okay. and support and educate parents. There's so much that goes into these cardiac kiddos, so parents do need a lot of support, a lot of education. So it can be a very scary process. Okay, so care is going to depend on the selected treatment of condition in question. Right. There's no one treatment for cardiac issues. That's just how it is. But we are always going to support the family and provide education. Pharmacology. There are some pretty important medications that we're going to look at. So captopril is one of them. What does captopril do? So it's a pril. Yep, so it's an ACE inhibitor. What else do we have up there? Digoxin, which is antiarrhythmic, sure. Yeah, we can go with that. And milrinone is up there too. We'll go into some of these in more detail. But these are the types of medications that you'll be looking at, right? Antibiotics, prophylactic for surgical intervention. A lot of these kids need some sort of surgical intervention. So antibiotics is just up there as a generic, think about it type thing. Okay. Effective treatment, we're going to gain normal heart function or palliative function. We'll talk a little bit about the differences between those two things. Some heart defects we can ultimately cure. Others we're just going to have to do our best, right? Child's going to perfuse adequately, free of post-op complications, which are unfortunate, right? Our complications are heart failure, endocarditis, which is one of our exemplars, and death, right? 25% of infant deaths. So, substantial. Questions kind of on our basic cardiac implementation and evaluation. It's hard to go basic with this because you really have to think about the specific conditions. Okay. Okay. So let's talk about cardiac catheterization. Has anybody had a patient who's had a cardiac cath or know somebody? Cool. So a little bit. What is a cardiac cath? What is it all about? What's that? Angiogram. What else? How is it actually performed?
So we go through the femoral artery and we use IV contrast and watch it on the screen.
Yep.
And if the contrast stops, there's a blockage there.
Right. Right. So that's one of the procedures done with a cardiac cath. So they'll go in through the fem. You go all the way up to the heart. They can inject the dye and then watch how the dye spreads, right, and determine if there are blockages. So really helpful for that. For kiddos, we don't do that quite as much, right? So we don't usually have the same types of blocks that adults do. But we do use it for a lot of different things. So it is invasive, of course, right? We're going to go through that fem, especially on our littles. You've got to go through the fem. It's the largest vessel. So femoral artery. It goes all the way up, goes through the aorta and into the heart. Like, how cool is that, right? It's crazy cool. It can be used for diagnosis and or treatment. So it can be both things. So as far as diagnosis, it can inject the dye. What else can it do to help diagnose conditions? What do you think? Test pressures. Yep, so that's a big one. As far as treatments, what do you think it can do? It can stent open, it can put a shunt in, it can also close, right? It can mesh close different holes, which is pretty amazing. It can be done outpatient. It is often done outpatient. But is this procedure without risk? Nope. So what's going to kill this patient?
Infection or bleeding?
Bleeding before infection, but yes. Yep, hemorrhage and infection. Right? So acute hemorrhage at the insertion site. And what are we going to look for there? Blood. Sure. Mm-hmm.
Down.
Potentially, yeah. If you're hemorrhaging, it's probably going to go down. Yeah, eventually, you know. It's not great. What do you think about, like, pulses distal to the site?
Oh,
Yeah, they're going to get real weak, right? Because it's the femoral artery that's bleeding out, so you're not going to have great pulses. So that's a pretty specific thing to think about here, right? But let's think about before we even do the cath. Pre-cardiac catheterization. So we need to have a baseline, okay? Because we're going to be thinking about, are these pulses the same bilaterally? Is this pulse the same as before the cath? And it's not uncommon for the pulse on the cath side to be a little diminished because it's going to clot a bit, right? You're going to have a clot there, so it might be a little diminished. But you do need a baseline. So we do vital signs and labs, pulses, perfusion, color, temperature, especially on the extremity to be used for catheterization. Ideally, the nurse who does the pre-cardiac catheterization assessment will do the post-assessment as well. If it's not, then make sure you take good notes. Leave the other nurse set up well to care for this patient. We're going to confirm allergy status, shellfish or iodine, contrast we might be using, right? We're going to prepare patient, age-appropriate language. And I should say, too, before we prepare here, one more physiological thing we need to do is to empty the patient's bladder. Make sure they pee. Right? Because we're going up that fem, so they do need to pee before this procedure. So I'd say vital signs labs, all that good stuff. Get the patient to pee, empty that bladder. Let's prepare the patient, and then think about the family as well, because mom, dad, caregiver are probably freaking out a little bit, right? And we're going to make sure that they've been NPO for 4 to 6 hours before. So, informed consent, how does that work? What is informed consent? How do we get it? What is the nurse's role in informed consent? Yeah?
So the provider has to do informed consent because you can witness that it happened as the nurse.
Okay, yeah, so provider does informed consent, and as the nurse, you witness it, right? How does that take place?
Face to face, verbally.
Should.
It should.
Should, yep. So ideally, you should be in the same room as the provider while they are talking to the patient. Okay? Do providers come and ask you to witness things after they've talked to a patient and you're not even in the room?
Yeah.
All the time. So what do you do in that situation? Do you just flat out say no? What do you do? So you go in and you talk to the patient, right? And what sort of questions do you ask? Did you just discuss this with the doctor? Yep. Yep. So on this form, these are the listed risk factors. These are the listed complications. Did the physician discuss all of it? You basically go over the whole form with them again. Okay. Now let's say the physician does all of that, and you're in the room, and then they step out of the room. Before you witness, what should you ask the patient? Do you have any questions? Because does that answer change when a physician leaves the room?
Yes.
Yeah, always, right? You don't want to ask questions in front of a physician. They get a lot of patients, not all, some are very bold and will stand up for themselves, and I love it. Others, though, get very intimidated. They get very intimidated, and they don't want to ask questions. They don't want to seem dumb. They don't want to, waste the doctor's time. Maybe, who knows what they're thinking. But a lot of times you need to wait for the doctor to leave. You ask them, and then I'll sign off on the witness. But like I said, some physicians will push you to do it even when you're not there. Just take a moment to confirm everything. You do want to make sure that the patient knows and the parent knows that this kid is probably going to be restrained. They will go through sedation. They will wake up probably in a fog, all that stuff. Make sure you talk about all of that before we do this. Just because it's an outpatient procedure doesn't mean that it's not, that it doesn't involve anesthetics and things like that, okay? Okay, so post-cardiac cath, pressure must be applied to the catheterization site manually and via pressure dressing. Okay, so we start by applying pressure directly to the site for about 15 minutes. And what can you tell me about applying pressure to an artery? Yeah, it's a lot harder, and we are not being ginger about it. We are pressing down hard, right? We're actually trying to occlude. We're trying to get a clot. We're trying to stop the blood flow. So this is not like a light press. This is a deep press instead. So it's going to be uncomfortable, right? It'll be uncomfortable for that kid. Hopefully they'll still be a little sedated, a little under, because it hurts a bit. Your goal is, a lot of times, like even when you're taking out an art line, right, you still have to put a lot of pressure. And the goal is to make sure you don't have a giant bruise surrounding it, but the ironic thing is sometimes they get a bruise because of your hand holding some tent, right? So same thing down here, a lot of pressure for 15 minutes, okay? After that, we're going to apply a pressure dressing. And have you all used one of those or seen those? So they're the fun, like stretchy, elasticy dressings. They're usually pretty wide, depending on the site that you cover. And what you do is you stretch them out, you put it on the site, and then you release. And it actually compresses the skin and the site for you. So it applies pressure just through the elasticity of the adhesive. They need to wear that for at least 24 hours post-op. And then they can put regular dressings. Okay. So the extremity used has to be immobilized immediately post-op. Why are we immobilizing it? So it doesn't start bleeding again, right? We just went through all this effort to stop the bleeding. We do not want a hemorrhage, so we need to immobilize post-op. And that's going to vary, depending. It might be just a couple of hours. It might be longer. Physician will write an order how long they want this extremity to be immobilized. Full assessment outcomes should be compared to baseline assessment. That's pretty obvious, right? After they come out, they'll usually get cute 15-minute assessments and then half hour, and then we'll go from there. Usually labs are taken immediately post-op as well. We want to see if we've lost a lot of blood. We want to see where we are. And then you're going to provide discharge education for parent and family. Okay? So if this was your kid, what would you want to know?
What are the signs to look out for?
Okay, yeah, what are the signs to look out for? What am I worried about? I'm worried about hemorrhage. So what are you going to tell a parent to look for?
Pallor.
Okay, so what would we say to them?
Your kid looks really pale.
We're looking, yeah, does your kid look pale? Okay, what else? Bleeding, yeah, so how can parents assess bleeding?
If there's a dressing, if you see blood coming.
Right, so if there's a dressing, is the dressing saturated with blood? We're going to worry. Yeah, that's something a parent can easily observe. Good, what else?
Swelling in the area.
Swelling in the area could be a sign of badness, infection maybe. What's that? Sweating? Yeah, again, that could be like infection, fever, could be infection as well. Not necessarily hemorrhage, but those are complications, right? So one of the things parents are going to want to know is just what are some of the complications? When do I call the doctor if something goes wrong? So everything you said is appropriate, right? Those are the things they're going to look out for at home. Let's see, what else do you want to know?
How do I do a neurovascular check?
Okay, how do I do a neurovascular check? Like, how do I make sure this limb isn't going to go numb? Or what do I do?
What's the temperature?
What's that?
What's the temperature of the limb?
What's the temperature of the limb?
Is
So,
it warm? Is it cool?
right, so that's one of the ways we can check for neurovascular status. Good. What else? What else are you going to tell that parent? You can check pulses. So some parents might be able to do that. Yeah.
What's their activity, whether they're allowed to? What are their restrictions?
So what are the restrictions? Yeah, so I would want to know that for sure. So we're going to avoid baths, right, for at least a couple days. Showers are okay, but you have to keep the site dry, closed. Good. What else? Anything else you want to know as a parent?
What their follow-up plan is with the doctor?
Yeah. What's our discharge plan? Like, when should I come back? Do I need to come back? When can they resume normal activity? All those things, right? So we're going to avoid any strenuous exercise for 24 hours, and we'll usually follow up a day or two later. Good. So those are the sorts of things you want to start thinking of, because sometimes parents feel bad about asking a lot of questions. So think about what questions you would want to know if this was your kid or your niece or your nephew or just, you know, your mom or dad, if they were discharged, whoever, a loved one. What would you want to know? And make sure you offer that information freely. Don't make the patient like beg for it. Right? Make sense? Cool. Questions on cardiac cath? It's a very cool procedure. Very cool. It's amazing how much they can do. Okay. Okay. So, congestive heart failure. We're now in heart failure. Function is impaired to the point where heart function is no longer adequate enough to meet the circulatory and metabolic needs of the body. So this is kind of like respiratory distress versus respiratory failure, heart disease versus heart failure. Okay? Now, what you're going to find is that in pediatrics, our signs for these exemplars actually mimic left-sided versus right-sided heart failure pretty well. And that's something you know, right? So I refer back to that when I'm talking about kind of the signs and symptoms that you'll see with some of these exemplars. So with left-sided heart failure, what are some of the signs and symptoms? What's that? Shortness of breath. Yep. What else? Dyspnea, nocturnal dyspnea. Pulmonary edema, crackles. Right? The left side of the heart can't eject enough blood, so it starts backing up into the lungs. Okay? So those are the things you usually associate with left-sided heart failure. What about right-sided heart failure? Peripheral or systemic edema. Yep. You can, yeah. Okay.
What was that last one?
Modeling. So diagnostics, ECG, chest x-ray, and an echo. Okay, so let's jump into some of these drugs, because they are super cool, right? So, anti-arrhythmia drugs such as digoxin, lanoxin, what can you tell me about it?
Slow down the heart to increase the amount of feed.
Right, so it slows down the heart to allow more time for filling and increases cardiac output. Okay? That said, what do you need to do before you give digoxin? Apical pulse for 1 full minute. No ifs and or buts. We hold it for infants if our heart rate is less than 90. And older kids, less than 70. Digoxin is a high-risk medication, right? So what does that mean clinically for you all as nurses? Frequentitis, okay, but before you give that med, what are you going to do? You want to know the levels, yeah, but I'm talking immediately before you give a med like this. Witness, it's a nurse double check. Yeah. You have to start thinking like certain meds you have to allow for more time for, because right before you get it, you got to get another nurse to double check it. And a lot of times that nurse is going to have to come to your computer, sign off on it, so it's not like a quick med you can just give. You got to do the apical pulse for a minute. You need to find another nurse to do it. So it can take a little while. So I heard a few people like chattering about it, but what's the big thing with digoxin? Toxicity. Yeah. So when I was in nursing school, we had a med-surg teacher who was like, she was awesome, but she was also like a little crazy. But in like the good way. Like she would stop lecture to show you pictures of her cats, because somehow the lecture pertained back to her cats. And she did have pretty glorious cats. But she would always talk about like certain medications, and when she got to digoxin, her voice was probably actually the same tone as mine. When she got to digoxin, she would always go, Digitalks, people! I literally wet myself because I would sit in the front seat, and so like I peed a little bit, and hopefully you did too, because now you will not forget about digitalks, right? And I suppose that was her point, but I think she was just kind of crazy. But digitalks is a real thing, right? And what do you need to know about digoxin toxicity? First, you need to know your levels, right? And I will tell you, I'm not going to have levels on the examination, but I have heard it's on NCLEX because it is a very high-risk drug, blah, blah, blah. So what are our therapeutic levels? 0.8 to 2. Yeah, 0.8 to 2. So it's a pretty narrow window. Okay? What are some early indicators of digoxin toxicity? Halos. So visual disturbances, halos. Yeah. Bradycardia. And anorexia. Loss of appetite. Okay. And is there a certain electrolyte that has a close personal relationship with digoxin? Calcium, sodium, potassium. Yeah, of course it's potassium. What else is good? Of course it's potassium. So what is the relationship between digoxin levels and potassium levels? As potassium levels go down, digoxin levels go up. So it's an inverse relationship. Okay? So you should be checking potassium, right?
Should we give it?
Should you give it? Well, that's going to depend. So once a patient gets on a certain regimen of drugs, if there's a change, then we'll go back to monitoring potassium levels, and we might have to give some, or we might need to hold things with potassium, right? We might need to play around with potassium. Is the answer. But hopefully we're going to get a patient to a stable medication regimen so that we're not so worried about their levels, and the only variable is their diet, right? And that's why NCLEX is probably going to ask you all about foods that are potassium, all that sort of stuff. I kind of forget. You probably know foods rich in potassium, right? You got that? Yeah, so go to her. She's probably good at that. I'm not, I forget. Spinach? Is that? I don't know, banana, something. Avoid potassium. Potatoes, is it?
Peas,
Oh, yeah,
potassium, oranges,
Apricot.
spinach, strawberries.
Oh, spinach is on there. I wasn't just making that up. Yeah. So those are things you'll need to know, right? Okay. So let's move on to ACE inhibitors. Captopril. So our prils. Those are the ACE inhibitors. So what does ACE stand for? Angiotensin converting enzyme. You knew that, right? Yeah. So it's inhibiting this, right? So it's stopping this enzyme from working. So angiotensin is not converting. Right? So what is that going to do? So what usually happens is angiotensin 1 converts to angiotensin 2. Angiotensin 2 is a vasoconstrictor. Okay, so if that's not happening, what is happening? Right, we're not constricting. We're going to be more dilated, right? So it promotes vascular relaxation. Okay, so it'll decrease systemic vascular resistance. That said, what's your most common side effect?
Coughing.
Most common serious side effect. I mean, you can have the dry, like an irritating cough. What was that? Hypotension. That's the one we worry about. So what do you need to do before you administer this one? Blood pressure, right? So digoxin, we get the heart rate. Captopril, we want the blood pressure. Good. Okay, so our beta blockers, metoprolol and LOL. Tell me about those.
Increase the heart rate.
No. It doesn't increase heart rate. What does it do?
Decrease. I said
Oh, you said decrease? Oh, then you're good. Yep,
Okay.
decreases the heart rate. Yep, no, you're good. You're good. Sorry. So it's a competitive antagonist. It binds so that other things can't bind. What can't bind? Beta. Yeah. So we're blocking beta. Beta 1, right? We have one heart. So if it's going to slow the heart rate, it can result in bradycardia and hypotension. A lot of older gentlemen do not appreciate the non-beta blockers, and they will be non-compliant. Yeah, erectile dysfunction. Yeah, so that's why, of course, they all want Viagra. I don't know, but then it works against the beta blocker, which whatever.
They don't care.
No, they really don't. No.
They're ready to go out.
Little blue pill. I know they're gonna go out happy. Diuretics. Furosemide. What can you tell me about furosemide? Potassium wasting. Right? So you're going pee out potassium. It stops reabsorption of water and salt. Okay. A lot of people who are on furosemide are on furosemide because they have heart failure, right? So what medication are they also on a lot of the time? Digoxin, right? Which is sensitive to what electrolyte? Potassium, which is wasted by awkward, right? So you gotta remember, if you adjust your digoxin or your furosemide, either one of them, you're going to have to get levels drawn, you're going to have to see your primary more frequently or your cardiologist more frequently, because any change in those medications, one will affect the other. Okay? Now, once you get to a stable level of these two and you're just taking them regularly, then we're not so worried. But, you know, you miss a dose of your furosemide and you ate spinach banana salad, well, we might be in trouble, right? So think of that. What about spironolactone? What can you tell me about that? Potassium sparing. All right. So that might be good for certain patients as well, those that need to hold on to potassium. Questions about our wonderful pharmaceuticals? They're all very cool. We do neat things. And every older person is on them, so you know. Good to know. Okay, so palliative versus corrective when we're talking about surgery, right? A lot of times we can't fix it. We're just going to do our best to increase quality of life. Pre-op considerations, we're going to think about a physiologic and psychosocial assessment. So physiologic assessment, what do you want to know about the skin? What's the big question we ask about a lot of these heart things? Are they going to survive? Are they going to survive surgery? Right, that's the number one question. Is this kid strong enough to survive surgery, cardiac surgery? It's not a small thing, right? A cardiac cath, that's much more manageable, but actual surgical correction is substantial. All right. Psychosocial. What do we think about there? Family support. Yeah. This is not a, oh, you got surgery and you're done type thing, right? Like there's a lot that goes into this. So what does their support network look like? Are they single parent? Is this getting foster care? Is the marriage stable? Unfortunately, a lot of marriages fall apart in front of your face, isn't it? It's really sad. Okay. So the ability to care for the child at home pre and post-op is really important. They're not going to do a surgery if this kid's going to go home and immediately have to get readmitted, right? So if that's the case, then they have to figure out some sort of rehab center, or a lot of planning goes into it. Monitor for signs of complications, which could be many. Strict eyes and nose. Chest tubes. Chest tubes are pretty cool. Have you done those yet? No. So chest tubes. What do you know about them? What do we, as nurses, assess for when we're thinking about a chest tube?
Blood or fluid in the container.
Blood or fluid in the container, right? Initially, when somebody has a chest tube, what color fluid do we expect to be coming out? Initially red, what we call probably like serosanguinous, right? Sanguinous or serosanguinous. Okay? So initially red, and then drain, less, pink, and then straw color, right? And once we get straw color, what do we call that? Serous, yep, serous fluid. Okay, so we are at straw color, and kid is nice and still, and it goes red again. What do you think? That's not good. That's not good. We are serous, and kid turns onto his side, and it goes red again. Sanguinous. What do you think? No, I'm not actually as worried about that, right? Because if it's just a shift and blood that was pocketed over here all of a sudden makes its way down, that's all right. I'm not sending out the alarm yet, but I am a little heightened, right? So I'm going to watch that closely. If we go back to that nice clear color fairly quickly, then I'm going to feel okay. If it's been like a good 5-10 minutes and we're still draining like blood colored, then I'm worried, right? Kind of get the distinction there? Good. What about bubbles? You know anything about bubbles in a chest tube? Yeah, so there's seals, right? There's a water seal. It goes from the chest into the water seal and then to the drainage. So a lot of times, initially, you'll have bubbles, and that's fine. Because there's probably some air trapped in there from the surgery, right? So bubbles are just fine. It's being sucked out, goes through the water seal, bubble, cool. And there's no saying how long it's going to bubble for. But when it stops bubbling, do you expect it to start bubbling again? No. So that's just like with the blood thing, right? Kid moves, okay, I don't mind if there's a few bubbles. That's just a shift in positioning. Somehow some air that's trapped is now been released. That's cool. If it keeps bubbling, what do you have? You got a leak somewhere, right? That's no good. That's no good. So if you have a patient with a chest tube, you'll always have a checklist of things that you need to keep by the bedside, because you need to be able to cover the space up so that you don't end up getting underwater and air gets sucked into the hole, right? So, no good. The chest tubes are pretty cool. Pain control. A lot goes on there. PCA is probably the most common form of PCA. Pain control for these kids. Positioning. You have to think about that sternal incision, right? It's going to be there for a while. And if you've got a toddler, what's the really tricky thing? What can't you do with a toddler? Even after they've like started running around, yeah, you can't pick them up, right? You can't pick them up under their arms, which is what toddlers love. So you have to get like used to the butt scoop to pick up those kids. If you pick them up under their arms, you're liable to rip open some of their incisions. So that's not good. In case anybody was wondering, it's not what we're going for. So, cardiac kids are incredibly varied, right? So, here's a cardiac kid, super cute, right? And these are taken off of vlogs. So I think this was like 3 days post-op or something. This kid's chilling, got a little Bears bottle. You can see that we still have quite a bit going on. We still got some tubes going, all that good stuff, right? But this, not so bad, right? We can deal with this. Also 3 days post-op is this little, right? Yeah, got the, that's right, like 3 days. So this one is still intubated. We still have, you can see the fent. So fentanyl still going, still leads. This is a chest tube right here. And you can see it's still red, so we're still putting out a good amount of blood, art lines, everything going on. Right? What's the difference between these two kids? Age is a big one, right? The condition before going into surgery could have been vastly different, right? What happened during surgery could be vastly different. You never know how these kids are going to come out, and that's why it's so important to prepare the parents for anything. Okay? Hopefully we're going to get this kiddo out though. Okay? But you never know. You never know what you're going to get with cardiac. So just make sure everybody's on the same page. Okay, so that's our general cardiac care plan, right? Anybody have questions about that before we jump into our exemplars? Yeah.
Quick question about the cardiac catheterization. Do
Yeah.
they typically have any kind of chest sensation after the catheterization procedure?
Yeah, so that's a good question. So with the cardiac cath, they should not really have sequelae in the chest. Now, during the catheterization, they might develop arrhythmias, or what we call ectopy. And does anybody know what that means? If that happens during either a central line insertion or during the cardiac cath? It means they went too far, right? They went too far, and now they're tickling the heart, and the heart's going, hoo, and some sort of ectopy, right? When you don't know what arrhythmia is, you just say ectopy to try to sound smart. So some sort of ectopy will occur, but it should be really transient. When they stop like tickling the heart, it should go away. If it doesn't, if they're still having palpitations or still having ectopy post-cardiac cath, that's not a good thing. That means that something is wrong. So transient ectopy, a little bit of flutter during the procedure is okay. We don't affect it. Does that answer the question?
Yeah.
Cool. Other questions? All right. So our exemplars, these are so fun. They are. And we're doing a curriculum revision, and they're getting rid of like all of that. So I'm glad that I am leaving, because I love these. This is like half the reason I took this job. For my interview, I gave a mini lecture on tetralogy of Fallot. So I love them. Hopefully you will too. I think they're super interesting. The first ones we're going to talk about are defects that cause increased pulmonary blood flow. Yeah.
Do you know if they're replacing these techniques?
Oh, I think just tetralogy of Fallot, and they're getting rid of everything else. Which, I mean, in some ways makes sense for preparing nurse generalists. And
I thought I was kind of rare.
Tetralogy of Fallot?
Yeah, because I had a patient that at clinical, and the instructor told me to look it up, and when I looked it up, they said it was rare, but...
It is pretty rare, but it combines everything.
Yeah.
So I guess that's fine. Yeah. But yeah, it's pretty cool. I mean, it's going to be a really great curriculum, and it's not going to roll out for probably years because everything takes a long time. But PDA, patent ductus arteriosus, failure of the fetal PDA to close after birth is going to cause increase in pulmonary blood flow. And a VSD, ventricular septal defect, again, abnormal opening in the septum between the right and left ventricles is going to increase pulmonary blood flow. Okay? So, quick recall. What causes the PDA to close? Decreased prostaglandins, increased oxygen. We'll close this up. If those conditions are not met, the PDA is going to stay open. Okay? What populations do you think might this be common in? What kind of kids might have an open PDA? So preemies, might, yeah. Preterm infants, especially if they're in respiratory distress, right? They're having trouble breathing. They'll probably stay open. A PDA will occur in approximately 5 to 10% of kids with heart defects. And I'll show you the difference. Ready? Okay, so here's our normal heart, and here's our PDA. Right over there. So it's a minor difference, right? It's not a big difference, but it has a pretty big impact. So, looking at this heart, this is a fairly normal heart, right? Where is the area of highest pressure? Left ventricle. Okay. So normally left ventricle pumps and the blood goes up through the aorta, shoots out through all of the different areas and goes to the body, blah, 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 right? So all good. In this case, left ventricle is pumping at the same time as the right ventricle. They're both pumping at the same time. But remember, the left has higher pressure and is a little bit stronger. Okay? So it pumps, and then it hits this PDA. And which way does the blood go? Down. It beats the pressure out in this right ventricle. Because the right ventricle is pumping into the pulmonary artery, that's the pressure that we're thinking about. So left ventricle has higher pressure, and that's going to shunt the blood through the PDA into the pulmonary artery. Okay. And where is that blood going to go? The lungs. Right? So we have some oxygenated blood shunting into the PDA. And then all of a sudden our lungs are getting extra fluid. Does that make sense, how they're getting the extra fluid? You get it? Good. What's going to happen to this right ventricle? Yeah?
Sorry.
Don't be sorry.
Is there ever like a case where that increased aortic pressure pushed down and could cause like a valve prolapse? Keeping down, pushing the opposite way.
You mean over here?
Yeah.
Yeah, so I would, it could, in theory, but the pressure difference is not so significant that this side is so much stronger that it would prolapse the valve. It could. I mean, I'm not saying that's out of the realm of possibility, and I like that thought, because it is putting pressure on the wrong side, right?
Mm-hmm.
But I mean, the right ventricle is still pretty strong. It's still pretty strong. But what's going to happen to that right ventricle eventually? What do you think? It's going to get tired. Before it does that, it's going to become yeah. And I can't say this word. Hypertrophy. It's going to experience hypertrophy. It's not hypertrophy, which is how it should be because it's spelled hypertrophy. But no, if you say that to a physician, they're like, what? I don't understand. Yeah, they act like they don't understand you. So before I moved here, I lived in Massachusetts where they have like crazy place names. And I lived in Salem, Massachusetts, and right next to that was a place called Peabody. So I called it Peabody, right? Like Peabody. And I would be like, oh, I'm going to Target in Peabody. Where? Peabody. Where? Oh, you mean Peabody. Yeah. You know what I was saying. You stop it. You stop it. But I do miss it there. But yes, Peabody. So this is hypertrophy. Hypertrophy. So right side of the heart is going to have to work harder. Eventually, it's going to become hypertrophic. Right? It's going to get bigger. And then it's going to get floppy. Because it can't hold that. It sounds good, like, oh, it's big and strong. No, it's actually not good. It's going to get weak and flabby eventually. I feel like there's an Arnold Schwarzenegger joke there, but I don't know his current health. So, I don't know, is he like flabby now? Anybody? No. Okay. Still pretty strong? Okay. So ventricular septal defect, VSD. That's where there is opening between the two ventricles. Yep. There it is. Whoop. Okay, and how can you predict which way the blood is going to shunt? Because the left ventricle is the area of highest pressure, and it's going to push to the area of lower pressure. Now, how does this result in increased pulmonary blood flow? Yeah, so it's going from the left here, and it is right under the pulmonary artery. So as the right ventricle pumps, it shunts a bunch of extra blood up through the pulmonary artery. Right? Does that make sense anatomically, how that would work? Okay. This is the most common congenital heart defect, and it's often found in combination with other things. This causes a murmur, and it's oftentimes innocent, right? When A lot of kids say like, oh, I was born with a hole in my heart, but I grew out of it. This is a lot of times what they're talking about, is a VSD. So if it's small, it's really not all that impactful. If it's big, then we worry. Okay. So let's talk about the signs and symptoms of PDA and VSD. I really want you to pay attention to the both column because that's what we're looking for, right? We're looking for commonalities. So with the PDA, you're going to see all of this. The VSD, you'll see all of this. For both of them, this is what you're going to see. Potentially asymptomatic. So there might not be anything. Right? For both of these conditions, a lot of times we won't see it. But we might see signs and symptoms of congestive heart failure that you would be familiar with. Which type of heart failure do you think these signs and symptoms mimic? Left-sided or right-sided? Left-sided. So it's all those lung things, right? The crackles in the lungs, the pulmonary edema. We have increased pulmonary blood flow. Okay, so this would be signs and symptoms of left-sided congestive heart failure. Now, mind you, it's not left-sided heart failure. I'm just phrasing it that way so that you can make the association between the signs and symptoms you know with the signs and symptoms presented. Increase in pulmonary infection. Makes sense, right? Lots of juiciness down there. And increased incidence of failure to thrive. Cool. Nursing diagnoses might include ineffective breathing pattern, risk for infection, risk for excess fluid volume. Planning, our child will not show signs of heart failure, not show signs of respiratory distress. Family's going to know at least 3 signs of developing CHF. What do you think 3 signs might be? Shortness of breath. Are parents going to be able to hear crackles though? Yeah, probably not. They might see weight gain. Yeah. What else? We want at least 3 signs. Hemoptysis? Hopefully not. But maybe. Lightheadedness, maybe if they're not perfusing well enough, we could throw that on the list. Or like lethargy, things like that. Yeah. I'd say those are things that parents can actually see. With kids too, it's probably going to be a decreased level of play, because they're having trouble breathing, carrying around all that extra fluid. So, yeah. So we're going to feel comfortable preparing for testing and surgery. And what are we going to do about these things? So, with PDA, there may or may not be a benefit to closing it. And we'll go into that. Some kids need a PDA. Some kids, it's actually good for them to keep this PDA. But if we decide we are going to close it, we can actually do it pharmaceutically with ibuprofen or indomethacin. And what is indomethacin? We'll keep it open.
Wait, no.
Mm-hmm.
That's the nickel, so it has the inside active.
Yeah, NSAID. Yeah, perfect. So these are NSAIDs. Okay. So they also function as prostaglandin synthase inhibitors. So basically, even if prostaglandin is still in the system, they stop it from getting to the PDA, even though close enough. Okay. Used in preterm infants, 10 to 14 days of life. Still open at that point. Okay. Surgical closure, transcatheter closure, cardiac cath. Right? You can work with it. You can go in with a nice mesh and on both sides, close it up nicely. Pretty cool. They used to do VATS a lot more often, but we're finding more and more they are not doing that. So kind of good to know. A visual assisted thoracoscopic surgery. It's not open heart. They get like small little incisions here, and they go in, do that. But more and more you're seeing just cath, cardiac cath closure. VSD. Small VSDs will usually close on their own within the first 6 months of life. We just let it ride. Okay. If the child starts to show signs of heart failure, they might do something called pulmonary artery banding. What do you think that is?
Or being one way.
They put a band around the artery, yep, and close it up, right? So not as much fluid can flow to the lungs. Okay. This has been done less and less lately. It's not all that effective with that, but might still happen. Yeah.
Nothing they reverse when the child gets older.
They could, yeah. In theory, if the child goes out of the VSD, or if it's corrected, then they would probably need to undo that. Corrective surgery is better. Device closure by a cardiac catheterization. So that's the first choice, if they're going to try to do a cardiac catheter closure. However, if it's too large, if it's too big, or if the VSD is too close to the valves, they might not risk the cardiac cath. Okay? They don't want to go in and accidentally mess up the valves. So, in that case, they would probably switch to open heart surgery, which of course is really invasive. They're going to wait till kids like a year old, maybe. Okay, so our ideal outcomes: patient will gain normal heart function and be free of post-intervention complications, adequately oxygenated. We can develop some complications, such as pulmonary hypertension. Anybody at Mount Washington have a kid with pulmonary hypertension? No, primary pulmonary hypertension. So what do you think it is? Think critically. Hypertension is? Okay, pulmonary is? Boom. Boom. Yeah, so it's just high blood pressure in your lungs. That's all it is. This one, we can go back to our little pill. Anybody want to take a guess as to what this is treated with? Viagra, sildenafil. Yeah. So Viagra will treat pulmonary hypertension. So it's kind of weird. You're giving Viagra to like this little 1-year-old baby.
Is it just Viagra or anything in that class?
It's anything in that class, but Viagra was just mostly used because probably insurance reasons, to be honest. Recurrent pneumonia, development of heart failure are all complications of an untreated PDA VSD. Feel good about that? All right, awesome. Let's take a break. Let's do 15 minutes. Come back 7:30.